Dr. Payne Show, ready to roll. It's 1-855-55-Dr. Lou. That is to contact Dr. Lou outside, or even now if you want to give him a call. He'll have a service happening there, info@paincarecanada.com. And a reminder, of course, this is a call-in show, so we'd like to talk to you about any pain concerns you're having, health concerns. Bring them on. We'll talk to you over the next hour and get her done. How you doing, buddy?
Hey, good. Happy New Year, John.
Happy New Year to you, pal. What's going on in your corner?
The same old things. It's been a quiet holiday season. I've been off for a few weeks for a little bit of a vacation, so I'm back to the swing of things on Monday. But nonetheless, I was taking calls during the week for the people reaching out about their concerns. One interesting call that I had was, again, it was a gentleman who had an ultrasound of the shoulder, and there was a partial tear of a tendon, and he was told that was the cause of his pain. He had been getting therapy for that and still not getting better. And, I tried to explain to him, and it's something that we've gone through, ad nauseum, I think, but I'm happy to continue going through it, that what you see on imaging is not necessarily always the problem with the person. So you have to correlate what's happening on imaging with what the person experienced during functional tests. And that's something that I find is missing a lot. And a lot of practitioners out there are just sending patients for, tests like ultrasounds or x-rays, and there's incidental findings on these x-rays and ultrasounds. Most people will have something. It's very unlikely that anybody would have nothing, because as we age, things break down, and there's things that are just normal, the normal part of the body's breakdown, and things like partial thickness tears and degenerative disc disease or degenerative joint disease, depending on the extent of these things, can oftentimes just be simply normal. That's not to say that they're never significant or the cause of the person's pain, but it needs to be correlated, and it's not enough.
Right.
And it's incredible how many people I speak to that after I say, okay, well, you had this imaging order, you had it done. Did the doctor do any tests on you? No, did no physical tests. So you're not correlating it, and if you're not correlating it, you can't be certain that that's the answer. And so I think that's a big problem out there, and that's not just for the shoulder. I only use that example because I made this call yesterday, and I was thinking of it driving in today, that there's this consistent problem, I think, in our system, in our healthcare system, where there's too much reliance on these things. Now, another thing that I find is oftentimes doctors will go through all the findings on the x-ray with the patient, which is the right thing to do, but they don't talk about which are the things that are significant and not significant. And so a lot of times these types of things, like they're just reading a report saying, yeah, it says you've got a partial thickness tear, it says you have some mild osteoarthritis, et cetera, et cetera. It's the doctor's job or the practitioner's job to relay to the patient whether this is significant to them or not. And people shouldn't walk away with these things written on reports and assume that is 100% the cause of the problem, especially when it's very benign things like that. And so correlation of these types of findings on imaging with what presents in the office during a physical exam with a patient, I think is extremely crucial and often lacking. And so, I mean, if you're one of those people listening, or someone who's in a similar boat, I think it's your due diligence to get these things looked at the right way, and correlate these things with what happens in a physical exam and during functional testing. It's I think very, very important.
Well, you've mentioned before that sometimes you've seen on an MRI or an X-ray, what appears to be some pretty bad osteoarthritis or possibly a bulging disc in the spine. And you're going, man, how is that not causing pain? But sometimes the person's not complaining about it. You're like, wow, that you should be dying from that, but it should be killing you, but it's not. Yeah,
and that's a great point. That's the opposite end of the spectrum, where you see things that are pretty significant, like that you would think, wow, this should be putting this person in a lot of pain, and it's not. And that exactly highlights what I'm trying to get across, is that you can't look at these things as mutually exclusive. It can't just be an imaging result or the physical exam. It has to be put together, and a practitioner who understands both items needs to sit there and say, okay, where does this match up? Where is the source of the problem? I've met plenty of people. We run the knee clinic, and one of the things that we're really doing a lot of is PRP injection for knee osteoarthritis. I've met a lot of people with knee osteoarthritis. It's not the cause of their pain. In fact, I had actually, funny enough, I had another call yesterday of a person who in the summer was doing some work around the garden, twisted his knee the wrong way, heard a pop, had instant pain, right?
Yep.
Went to the family doctor, got an x-ray. Doctor said, no, this is just arthritis. Well, no, clearly not. Like, there was clearly a traumatic incident. Arthritis did not just set in that minute. Does he maybe have arthritis, degenerative disease of the joints? Yeah, he was an older person. I think he mentioned he was 68. So, of course, there's going to be some wear and tear. But that's clearly, just based on hearing, 3 seconds of the history, that is clearly not the cause of this person's pain. And to this day, he's still not better, which is why he's calling me. And I think that's, it's incredible. Like, are practitioners even listening when people are telling them things? Like, if someone explains a traumatic incident and the pain started immediately after that traumatic incident and they heard a pop, and there's all these things that really add up to paint a picture of something, and then you turn around and say, no, it's probably just arthritis. Well, clearly not. Like, I don't think it takes a doctor to appreciate that. I think anybody could listen to that story and think, that doesn't really make sense. And that's what he said to me too. He said, it didn't make sense to me because I figured if it was arthritis, like, I'd have other symptoms. I said, yeah, of course you would have had other things going on before as well.
Yeah, it could have been years of irritation and pain leading up to that point. So obviously not just, boom, oh, arthritis is here, welcome, how are you?
Yeah, exactly. And it's very, very different the way, degenerative changes or the breakdown of the body and pain related to that presents versus things that happen after an instant. And so, I think there needs to be, and this is one of the reasons why we do this show. It's not just the due diligence on the part of the practitioners, but patients need to understand this stuff. And you need to call out your practitioners if they're telling you things that don't make sense. And you don't need to be rude about anything. You just simply need to, state your point of view and try to understand. Like, my question would have been, well, how do you get there? If I've just told you that this happened after, July whatever date at this time, how can you possibly say it's a result of arthritis? And I'm sure that doctor would have been baffled.
Got to call out or call in. In this case, we'll take our first break. The lines are open for you for the remainder of the hour. Call in. You got questions about your pain yourself or for a friend. 416-870-6400, star 640 on cell as well. Dr. Payne Show just getting warmed up on this lovely Saturday morning right here at Global News Radio, 640 Toronto. Saturday morning, Dr. Payne Show is here until noon. Yeah, 416-870-6400, star 640 on cell is a number to call in. You have questions about your health, pain, concerns, bring them on. Would love to talk to you. Steve, thanks for chiming in this morning. How are you?
Good, you?
Good, pal. What's going on with you?
Not much. Tennis elbow and golfer on one side.
Oh, it's brutal.
Okay. And how did that start, Steve?
I'm a plumber, new construction, so it's repetitive motion, putting, constantly cutting pipes, roughing in home.
Yeah. Yeah, and so, I see here on the comments for the call-in that it's both sides. You've done cortisone, acupuncture, and nothing seems to be working. And you raise so one of the things when it comes to things like a lot of these functional injuries, we have to understand the pathophysiology, which essentially means why do these things happen? And you've already said it in what I just asked you, which is the repetitive nature of what you do. So, if you and it's often very, very hard for people to accept this, but if you continue to do, and this isn't me suggesting you shouldn't do your work, but let me just run through my train of thought. If you're doing the same thing that caused the injury and you're treating it, a couple times a week, even if you're doing some exercises, even if you're doing things like cortisone injection, but you're still doing the thing that initially damaged it, it will never heal. It's like having a scab that you continually rip off. That scab will never heal, and in fact, it'll probably get worse, infected, and other things will happen. And so this is a very big concern that happens with a lot of these types of injuries. Why a lot of these things end up becoming chronic is because people often try all the Band-Aid solutions to try to eliminate the source of the problem, not realizing that when it's something especially like a tennis elbow, which is very much repetitive strain sprain, or a golfer's elbow, whatever, is repetitive strain sprain, if you don't eliminate the repetitive action, then it never really heals. And that doesn't mean that you shouldn't be doing what you're doing. Potentially it does. Sometimes if it's a work-related injury, that's where under the rules of WSIB, you can be put on modified work to allow that injury to try to heal. Or sometimes it's about long-term modification of what you do. And so it's very, very hard when you are consistent with the repetitive actions, it often prevents that healing. So have you tried any modification of what you do? Like, have you gone on specified duties that would limit those types of things?
Well, I'm a subcontractor, right? So,
Yeah.
I get paid for what I do
Right.
by the hour.
Yeah.
I'm pretty sure I've been through the WSIB with other issues because of my job, so they don't technically like to pay.
Well, yeah. So this isn't me talking about the legality side of WSIB. That's not my job. My job is simply that the point that I'm trying to make here is if the repetitive action that is causing the problem is not eliminated, then oftentimes it doesn't heal, and it really is no surprise once you understand again that simple basic biomechanics behind it, why it wouldn't heal. It's never given a chance to heal. So
no, I get it.
Yeah.
But, I mean, now it would require a career change, and at my age, the kid, mortgage, it's kind of tough to do it.
No, absolutely, yeah. And so
my question is that because I went to my doctor and he's like, you know what? I told him about PRP and this one clinic that I was referred to, and he's like, you know what? Yeah. There's not really a lot of, good feedback on it. He goes, it's new. He goes, let's try the cortisone route first because it's practically free.
Yep.
And then he's like, let's go. And then after that, PRP would probably be my last resort, I guess, right?
Well, not necessarily. There is your doctor's right in that there's not a lot of good research for PRP in the elbow for these types of things. Mm-hmm. So it's very hard to say, on a case-by-case basis, some people might have good outcomes and other people might not. But, we always try to standardize our answers on these types of topics to the best available evidence. And right now there's a lack of available evidence for how good something like that is. Cortisone often, same thing. It often, in my experience, does not work. Sometimes it does, but your family doctor or whoever it was very right. It's relatively free, essentially. I think it's sometimes $20 or $30 for the actual medication, and then the injection component is covered by OHIP. So it's worth a shot. But again, no matter how strong the intervention, so even if you could do you go to cortisone, and even if PRP is a stronger, potentially for you a stronger source, again, with that repetitive action without now, and again, this is where I often have to see people. So this isn't me saying you have to change your career. It's often about just simply understanding what a person does day to day and how they can modify a lot of those things, or how they can build in breaks or some of the tools that they can use during the day. And so that's a lot of the times the things that are missing. This isn't me suggesting you need to find a new career at this point or you need to work less, but there is a fine line where you have to understand sometimes these injuries can get so bad. And I've had a lot of people that deal with work-related injuries, and they say the same thing, like, well, I need to keep working. But sometimes what people fail to understand is these things, if you leave them long enough and they get bad enough, it will prevent you from working just on its own, whether you want it or you don't want it. And so sometimes it's worth the calculated risk of time off now for long-term ability to work. And that's a big thing. And that's not just related to work. That's often related to athletes with their sports, where they don't want to take short-term time off of their sport because they're trying to achieve something, not understanding, well, that short-term time that you're taking off may save the longevity of your career. And so you're just an urban athlete. You're doing the things that most of us do day to day. And so you need to understand that too, that sometimes, a calculated amount of time off is potentially very, very important because it could save you some very long-term problems. And I've seen this. I've seen it on the other end. And a lot of people, as you're going through it, you're not seeing this stuff day to day. So, but these things can get bad enough where then, nerves can start to get affected and people can start to lose strength in their hands and they can't do what they need to do because of how bad the repetitive nature of the injury is. And so that's an important thing to consider. And you want to do the best that you can to try to fix that now, even if that equals some time off or some modification. And, I guess there would be a financial burden in that in some sense, but sometimes those things need to be done.
Yeah, well, it's the trade business, right? No matter what you do in the trade, whether I keep roughing in houses or whether I go and start snaking drains. I'm a plumber, by the way.
Yeah.
Right? It's, it's basically taking time off. I took a month off in summer.
Yep.
For vacation and, nothing.
But were you doing therapy and things like that during?
Well, no, I was on vacation, right?
Yeah,
so
but see, and that's the point is when you're taking. So even I think we have to go to break, but if you hang on, we'll talk about this more after the break.
Hang on, Steve. We'll get to you and your calls as well. Lines are open for the remainder of the show, of course. 416-870-6400 star 640 on your cell. Dr. Payne Show continues. Global News Radio 640 Toronto. Dr. Payne Show rolls on till around 12 o'clock this morning. And as a call-in show, your questions, your comments, 416-870-6400 star 640 on your cell. More of your calls on the way. Steve, thanks for hanging in, fella. Continue.
Yeah, Steve. So what I was saying before the break, and this is another thing I was just saying to Jody here, is that a lot of times people do exactly what you do. So during the repetitive strain sprain, that's when they're trying the interventions. But again, that's the double-edged sword. You're doing an intervention, but you're going back to the same thing. It's in the time that you're off that you should be doing those things like the cortisone injection, the acupuncture, the exercises, because then you actually give it a chance to heal. So, that's my best advice. If you're interested, you can come see me for an assessment. We could take a closer look and see, a game plan on how to try to get you better.
Yeah, definitely. I've been off now for 2 weeks for Christmas.
Okay.
And I've been doing the acupuncture and the massage and all that. So
awesome.
it's getting a little better, but, Monday, back to the beast. I'm back to work.
Right, yeah. Yeah, well, there might be things missing. It's often not just as simple as massage and acupuncture. It needs to be a multimodal approach of a lot of different things. So give me a call and we'll see what we can do.
Appreciate the call, Steve. 1-855-55-DRLOU. Dr. Lou is the number to reach out and contact, of course. Bev, good morning. How are you?
Good morning. Fine, thank you.
Good. What's going on with you?
Well, during the holiday, I developed it felt like a sprain in my wrist, severe pain, and then swelling up to my fingers. But it only lasted 24 hours, and it was not due to an injury.
Okay. How old are you, Bev?
In early 80.
And it's only on one side of your body?
It was just my wrist and hand.
On one side?
On one side, on the right side, that swelled up.
And have you had any previous injuries on that right upper extremity anywhere?
No.
No. Okay. I mean, what did you do after that 24 hours? Did you get it investigated at all?
No. I soaked it in Epsom salts.
Yeah.
And hot water, and then put a tensor bandage on it.
Yeah.
And within 24 hours, it was gone.
And it has not come back?
No.
Okay. Well, I mean, that's good that it hasn't come back. I mean, so I think in the event that it does come back, I would say even if it doesn't come back, I still think some investigation is warranted. I would say at the very least an X-ray of the wrist is warranted, and maybe even some simple blood work to check out inflammation levels in your body, just to make sure that there's nothing causing the inflammation is where I would start.
I was wondering if it could have been systemic related, like perhaps a pseudo gout or anything.
Yeah, and that's why I'm saying some blood work, checking for inflammation is a good idea, just to check it out. I mean, it overall sounds very benign. It's gone very quickly. You've been able to control it. It hasn't come back. So those are all good things. But I would still err on the side of wanting to know, or just to essentially make sure that an X-ray is important, just to make sure there's no lesions in the bone that would have caused something like that, and then some blood work checking for different types of things that can cause inflammation. Now, gout doesn't typically tend to affect the hand, but it's not impossible either. So checking for those types of things is good, but even just some standard inflammatory markers like ESR and C-reactive protein would be, I think, really important.
Okay.
Okay?
Thank you.
No problem.
Thanks.
Thank you, Ben. Appreciate that. You can reach out as well, 416-870-6400, star 640 on your cell anytime. Alice, thank you for hanging on. How are you?
I'm good. How are you?
Good.
Good. I have a question. I have CMC arthritis in my left hand. Actually, I have it in both hands. My left hand is much worse. I used to work in the automotive industry for 8 years. I stopped working in 2008. I got laid off. I'm a hairstylist by trade, so I noticed that my arthritis was getting really bad just using my tools and doing my job, basically. But what has happened is I also have a subluxation in the metacarpal in my thumb.
Yep.
I've been going to a physiatrist. For that, I had a nerve conduction study, and we did physiotherapy, splinting, everything like that.
Right.
I did leave the hairdressing industry because I just couldn't do it anymore. And my doctor would not do the cortisone shots for pain. He wanted me to go see a surgeon. So I do have an appointment this week to go see a surgeon.
Okay, good.
To address the subluxation, because that's really is causing a lot of pain.
Subluxation, yeah.
And
is the subluxation as a result of the arthritis because of how bad it is?
Yes.
Yeah, okay.
Yes.
Yeah.
So like everyday use, like my hand won't open up, my thumb won't.
Right.
Won't
Yeah.
operate.
I mean, I don't even need to. If joints are starting to subluxate as a result of the arthritis is bad. That's severe. So yeah. Okay. And so what's your question for me,
My
Alice?
question is, what can they do for me? I want to know kind of what questions to ask the surgeon. I'm really scared about surgery.
How old are you, Alice?
I'm 49.
49. Yeah.
And I do, like, my hands are pretty bad.
Yeah, of course. I think some of the things to ask for is, so I think number one, you need to understand that, when you're dealing with things like simpler joints where there's only essentially one joint, like say the knee joint, they can replace joints, those joints that have very bad osteoarthritis. Unfortunately, in the hand and the feet, the replacement is very, very hard. So oftentimes it'll be a fusion of the joints to essentially eliminate the joint. So you just fuse it. That way it can't bother you anymore. And that's pretty good short term. The problem with fusion is that wherever mobility is lost, it has to be made up in other places. And so then now surrounding joints, because there's so many carpals and metacarpals, right?
Yeah.
We're not talking about just one joint here in the hand. Whatever is decided to be fused, the adjacent ones that are still unfused will often have more motion because they have to make up for it, and that increased motion leads to further breakdown of those joints. So, and that's a problem. I find with fusion of the foot, it's very tough because then it changes the way people walk and do things with the hand, because obviously you're not walking with your hands, but it will change a lot of your day-to-day activity that you would need to do with your hand, because there will be an extent of mobility that's lost. So those would be my questions. So what is the game plan, right, in terms of how do we treat this, and then what happens after we've treated this? Like how does that, what's the likely outcome in 5 years, 10 years, because you're still very young. So we have to take a break. Alice, hang tight and we'll talk a little bit more after the break.
Thank you.
Alice, appreciate that. Hang on. We'll get to you and your calls as well. 416-870-6400, star 640 on cell. It's a Dr. Payne Show right here. Global News Radio, 640 Toronto. Dr. Payne Show, you want to reach out when the show's not on, 1-855-55-Dr. Lou, DRLOU, info@paincarecanada.com. You still got plenty of time to call into this show. It is a call-in show, of course, till 12 o'clock this morning, 416-870-6400, star 640 on your cell. Alice, thanks for hanging on.
Thank you.
Yeah, so Alice, so those are some things to very much consider. The other thing that I think is important is that you probably try least invasive to most invasive in that kind of order, right? So it's a good idea that you're being referred to a surgeon, to a hand surgeon for the cortisone, because it very much matters where the injection happens. And so obviously someone who's an orthopedic surgeon dealing with the hands is going to be much better than a family doctor at that. So I think that's a good call on the doctor's part, because that increases the prognosis of getting an injection. I mean, cortisone is going to break down the inflammation. As I said, the outcomes are usually not tremendous. Some people do find it works. And, I mean, even if it does work a little and you have to keep doing it a little bit, I think before you jump to more invasive interventions like the surgery, I think those are probably good options. But unfortunately, there's nothing that anyone's going to be able to offer you and say, here's a cure for that, right? So it'll be, how do you manage it and what are the best ways to manage it?
Can you manually, through physiotherapy, fix a subluxation? Or is it just...
No, it's a result of, because of so what happens as arthritis, so when you look at a joint space and as the bones get closer and closer, as they impact, and if they continue that impaction, then they'll subluxate because there's nowhere else for them to go. Because the whole process of arthritis is continual degradation of the bone, where it gets closer and closer, and once it's already touching, then once it keeps putting pressure and more bone is laid, because through something called Wolff's Law, which is essentially that bone will lay down more bone when contacted on, that impaction will just cause joints to subluxate. So they might very well be able to, depending, and I'd have to see it, they might be able to remove some of the arthritis, like go in and create like almost like an artificial joint. But again, it will continue to happen, and that really very much depends on who you're seeing for the surgery and what their recommendation is, and they're obviously going to be better at making that recommendation than me. But I think considering that option is important.
One other question.
Yep.
What's the problem with my thumb? Is it possible that, because now I'm having, I pronounce it incorrectly, so pardon me, osteophytes in my...
Osteophytes, yeah.
Yes, in my knuckle at my index finger.
Right.
Now, is that a result of the progression of the CMC? Yeah.
So that's osteophytes, or what I was talking about, which is Wolff's Law. So that bone gets laid down when there's an approximation of a joint, so more bone is created. That is usually in the form of osteophytes.
Because my knuckle at my index finger, I got a big one there, and it is causing me pain within the last 6 months.
Yeah,
and I've often thought, is that because of the initial CMC arthritis that's just causing all the stress? Because I do have a lot of muscle and tendon loss, or muscle loss from it.
Right.
It looks different than my left hand.
Yeah, I mean, is it a result specifically? I think you have arthritis in your hands. CMC is the carpal metacarpal joint, so they're just saying that that's the initial place, but you can have the phalange metacarpal joint, so you can get arthritis in those areas, and for whatever reason your hands... you don't have any type of systemic arthritis, like an autoimmune, like a rheumatoid arthritis or anything like that, do you?
Years ago, I had, and I'm talking about like maybe 8 years ago, I had the RA test done.
Yeah.
And it came back negative.
Good.
Is there any way that at that time it would have been negative and now it could be positive?
Yes,
because
potentially.
I'm having problems with my hip, my shoulder.
Yeah. So
neck.
Have you ever seen a rheumatologist?
Not since years ago, and I think I really should.
Yeah, I think you should too.
I think, like my neck, my faucet joints in my neck, I had a X-ray done.
Yeah.
I'm falling apart.
Yeah, no, I think definitely it's worth seeing a rheumatologist if you've got this type of severe degeneration at 49. See, this is the opposite of how I started the show, saying that oftentimes the wear and tear is incidental, it's a part of aging.
Right.
But you're 49 and have severe osteoarthritis that's causing subluxation of joints, that's not the normal aging process, right? There's something there that is causing that. Now, a lot of times it could be related to the work that the person did. So you mentioned you used your hands a lot, so that sort of makes sense. Maybe you did other things, and it could just be mechanical, and those areas are breaking down faster. Right. Or it could be something more systemic and autoimmune based. Then, having that test done a long time ago means that you didn't necessarily have the markers at that point. But there's other different, like just beside rheumatoid arthritis, there's a lot of different types of arthritides like that can cause this type of presentation. So I think you do need to see a rheumatologist.
I'm going to do that.
Yeah.
I'm so glad I called. Okay. I'm driving home and I just flicked on the radio. I love 640. I listen to you all the time, and I thought I got to call.
Okay,
and I'm so glad I did. Thank you so much
problem.
for the
Good
advice.
Luck. No problem.
I'm going to a rheumatologist.
Okay, good.
Thanks, Alice. Appreciate that. That is exactly how it works. Lines are open for you as well. 416-870-6400, star 640 on cell. This is a call-in show. That's how we get the ball rolling with people that call in. Dr. Lou, subluxation, I mean, this is a common thing. I've had it in my lower back for, forever. So describe once again, what does that actually mean? What are the joints doing once they build up?
Well, when a joint truly subluxates, so if a joint dislocates, it comes fully out of place. A subluxation is a partial dislocation. So I think when you're talking about a subluxation in your spine, you're probably referring to a chiropractic principle of subluxation. That's very different than what a medical subluxation is. And so when I'm talking about subluxation, I'm using the medical term, which is a partial dislocation of a joint, such that Alice was explaining, and not necessarily related to, like, quote unquote alignment of the spine or whatever.
Can they get in there with osteophytes, or as you say, Wolff's Law, when bone keeps building on bone? Can they, for all intents and purposes, can they scrape it away? Can can wear it down to give you? Will that give you some relief? Possibly.
Potentially, yeah, they can wear it down. But again, when you're wearing it down, it oftentimes comes back just the same. But that might be part of her plan of management, is just really like in the beginning having that done several times, and then after that maybe you fuse it. So this is where. See, in medicine, especially things like this is where the art, because there's an art and a science to even something like the profession of healthcare, and this is where the art side of a surgeon would come into play, and his experience or her experience in terms of what they have found works best. Because there's different things that could be done, but you want to do the thing that will provide the most help and be the least invasive. Because having surgery multiple times, that's also every time there's a risk of infection, nerve damage, all these things that could potentially be worse than the problem that you have, essentially.
Again, 1-855-55 Dr. Lou, DRLOU, info@PainCareCanada to reach out when we're not doing the show. But for now, you still got half the show left to call in, give or take. You want to give us a call, at least 20 minutes anyway. 416-870-6400, star 640 on your cell. Dr. Payne Show rolls on Global News Radio 640 Toronto. And the short form is star 640. You want to try that as well as we get down into the last half hour of the show here. Scott, thanks for hanging on. How are you?
Hey, doing good today, thanks.
Good, brother. What's your concern?
Well, because of severe osteoarthritis, I ended up having my shoulder replaced 6 years ago.
Okay.
And as soon as I started to do the physical therapy, active range of motion, I wasn't able to lift my shoulder.
Okay.
So it's graduated from there, where the pain increased to the point where, like, I was physically sick. Every morning I woke up, and up to 5 or 6 times a day.
Mm-hmm.
So, of course, they had to start putting me on the opioids that I hate taking.
Yeah.
But the pain has increased dramatically over the years, to the point now where I'm on like 270 milligrams of gabapentin a day, plus 9 milligrams of hydromorphine, and I still have to take Dilaudid.
Right.
Whenever I spasm bad, I've been to 3 neurologists, and they all look at me like I've never seen this before. I've been to 3 surgeons, same thing. They give me that goofy look. I've had every test in the book, except, according to like your show is saying, nothing when I'm moving. I have a great pain doctor at PCC, and he's totally frustrated because he can't, give me some of these tests. I have to get it through a neurologist or something.
What test is that? I'm confused.
Anything, like I've had ultrasounds.
Yep.
But I can't move my arm.
Right. Yeah, but if you can't move the arm, that's the functional test.
Move it for me.
No, of course, and nor should they. So a functional test means whatever is functional for the person.
Yeah.
Yep.
I've had tests that would probably show it, MRIs and CAT scans, but because of my implant, nothing shows up. It's all cloudy.
Okay. So what's your question for me?
Well, I don't know where I'm going. Like, I'm ready to hop to the States or something because everybody's looking at me.
Well, I mean, this is an end stage type of thing. Like, if you had a replacement, things went obviously severely wrong. It's been a long time. This is now a chronic pain issue, and
but it's getting worse.
Yeah, of course, and it probably will. And so, there's no easy answer, and I don't think that going to the States would provide you any better answers. I don't think anywhere in the world would.
Like, I'm looking at nobody will go in and do a scope. They said it could be worse. Well, it can't get much worse. Like when I spasm, it looks like I'm Quasimodo.
Yeah.
The whole thing just tightens right up, back bends over, and I get severe spasm. It looks like I'm having a stroke.
Right, yeah.
Because the shoulder creeps up so far that it actually bends, it goes into my neck.
Right.
Screws my nerves up, and then blah, blah, blah.
Yeah, I mean, this is a very severe situation. It's very hard to say over the phone what could be done.
Yeah, the show was going about, movement.
Sure. Well, when I say movement, I mean testing people's function. So obviously, if a doctor says to you, "Hey, Scott, can you raise your arm?" and the answer is no, well, then that's the function. So, but if they can raise the arm, then you can challenge it further and do different tests. So that I don't think anything was wrong.
But what about with contrast? Would contrast show anything in an MRI or an ultrasound?
What's the question? Would an MRI show anything more? Contrast of what?
Putting dye in it.
Well, that's what would that? It would dye
wouldn't show up with it.
No, so when they put dye in things like veins, right? So you're looking at circulation. This isn't a circulation issue.
We're thinking it's more of like a thoracic outlet. All the things I have.
Yeah, but probably pressure on the nerves, but there's no. The EMG is the best test for that, and you mentioned that you had that done already.
Yes, I had, and I have a nerve conduction.
Yeah, and the nerve conduction.
There's nothing, you know what I mean? Till there's compression on the nerve when the symptoms happen, then nothing shows. But they never get it to that point. They've never done one where I'm actually having a spasm.
Right. Mm-hmm.
So I didn't know if there's anything else or, No,
and it's hard for me to say over the phone.
Yeah, I realize.
Yeah, give me a call after the show, and I'll call you this coming week, and we can discuss a little further and see if there's some options.
Thank you, Scott. 1-855-55 Dr. Lou, DRLOU is that number. Moving on to George. Hey, George. Good morning.
Yes, good morning, Dr. Lou. I have a problem.
Sure.
In that I need a hip transplant.
Okay.
And they can't give me one because I have a stent in my heart.
Okay.
And I did get some steroids in the right thigh, and I am due for another set on the left thigh later on this month.
Okay.
Now, the thing is, it does offer some relief, but not a hell of a lot.
Yeah.
And I don't understand why they don't ask the patient where it hurts and give the injections there, so to alleviate the pain.
Mm-hmm.
And to complicate matters, I also have a balance problem, so I am walking with a walker.
Yeah.
But it would be easier if I didn't have so much pain.
Right. So what's your question for me?
My question is there anything I can do to get the doctors make a prescription to give me some steroids where the pain actually is?
Well, so I can't comment on when someone is doing injections, why they're doing it in a certain area. I think that's something you have to discuss with the doctor that you are getting those injections with, and there's often a reason why they do it in certain areas. Now, if it's something like they're trying to block the nerve, then they would inject that area, and that may not necessarily be where you feel the pain, but where the source of the nerve is. It's very hard for me to say, but I think if you have those concerns, I would just voice them to the doctor that is doing the injections for you and understand why it's being done, and simply ask, is there a way to do it in the source of pain? But also remembering that a lot of times where you feel pain does not necessarily correspond to where the source of the pain is, and that's very, very often the case. So that may be the reason why, but I can't comment on that because I'm not the person doing those things to you.
Thank you very much.
No problem.
Yeah.
Thank you, George. Appreciate that. You want to reach out further, 1-855-55 Dr. Lou, info@paincarecanada.com. Let's get Joe in here quickly before we break. Hey, Joe, good morning.
Hey, how are you?
Good, pal. What's going on?
Good. My wife's suffering with Baker's cyst or Baker's knee.
Yeah, Baker's cyst, yeah.
She's been doing physio. The problem is she has to go to work. She works. She tries icing it. But, is there anything we can be doing extra? The doctor said if it gets worse to maybe do some injections of cortisone. Is cortisone safe, or is there any other... So
it's the Baker's cyst that is causing her the problem, or the Baker's cyst is secondary because she has arthritis in the knee?
I'm guessing the arthritis, but the knee is not as swollen as it used to be.
Okay, so Baker's cyst is often behind the knee. It's not visible.
Yeah, it's behind the knee. Yes.
And that's where her problem is?
Yeah, that's what they told her.
Yeah. So sometimes with strong enough manual therapy, you can actually release the fluid. So understanding something, a Baker cyst forms because the fluid within the joint seeps out and forms a cyst. It's often related due to either injuries in the knee itself or degeneration of the knee. So even if you eliminate the cyst, if it's related to, say, inflammation of the knee due to arthritis, it will just keep coming back. So yes, you can potentially break that down through therapy if it's aggressive enough. Sometimes it can be drained and has to continually get drained as it gets worse. The cortisone would be more for the pain. I'm not really sure. I would think that if it's an actual result of how big it is putting pressure on things, that draining it is the best idea.
Okay, so just keep getting drained, ice, and any.
Well, and also understanding what the root cause of it is, right? Because it's it's often secondary to an injury of the knee or osteoarthritis.
Sorry, they said there was there's no damage to the ligaments or anything like that. So
does she have arthritis? So it might be related to arthritis of the knee.
Yeah, and like the job she has is she's on her feet a lot and stuff. So.
Mm-hmm. Is she heavier, or I know that's a bad thing to ask a husband.
It's true, but and also, is there any supplementation that can help in general with stuff like that? Like
at that point, like you mean like natural supplements, like glucosamine, things like that.
Not to reverse it, but at least to maybe give any kind of help at all.
It's hard to say those things, and I need to see a person in order to make specific recommendations, but oftentimes supplements, when things are that bad, often don't provide tremendous relief. They're much better for prevention.
Justine, Brad, I see both of you there. Hang on. We will get to you as we take a short break here. Dr. Payne Show continues. Global News Radio, 640 Toronto. Back into a Dr. Payne Show in the last few minutes here. We'll continue on with our calls. Justine, thank you for hanging on. Hello. Good morning.
Good morning, gentlemen. Love the show.
Thank you.
Yes, and especially Dr. Lou.
You like me more than John. I think
doesn't?
So, too.
Who doesn't?
I love John, too. I listen to him on the Lior Samfieri show, too.
Oh, there you go.
But you probably like Lior better than him anyways.
Well, you know, a pattern is starting to form here. Go ahead, Justine. What's going on?
Okay. I'm a truck driver, and I pull 2 trailers, and there's a lot of manual work. It's very all body parts are in motion. I fell at work in September at a facility on my right side. My hand caught my fall. Thank God it was on concrete. Thank goodness my head didn't get cracked open. And so I've been doing, as per WSIB, I've been doing physiotherapy for several weeks. And you were talking with another caller about subluxation. Well, in my hand, I have a bone growth, and it's touching a nerve.
Okay.
But the hand is getting better,
right?
As long as I don't use it. But now I have cracking sounds and pain at my shoulder. And just recently, now there's pain if I stand or walk for an extended time, like not even extended time, maybe, 5 minutes, and I walk fast. I started feeling pain on my left side of the torso, like there's like nerve pain in the back. And so I'm wondering, I told my physiotherapist that yesterday, and she said, I said, well, maybe, it's chiropractic. And she said, I think that's a bit of a stretch. And I said to her, oh, pun intended, right? So anyway, I just thought, well, it is possible, isn't it? I mean, I did fall on my right side, on my shoulder, my hand. So
what are you saying, like that it's potentially related to your spine?
Yeah, on the left side.
Yeah, potentially. Yeah, absolutely. Yeah, it's definitely not out of the realm of possibilities, especially if you're having all those symptoms. What I always say when it comes to when people ask me, like, should I be seeing a physio or a chiro or a massage therapist for this? My answer often is I'm not going to tell you the profession, I'll tell you the person, because I know some incredible chiros, I know some incredible physiotherapists, I know some incredible massage therapists, but I've also met bad in each profession. So it really is about finding the right practitioner whose ideas make sense to you and sound like you're being explained, it all is adding up, there's nothing there, no red flags are being raised in your mind, and I don't think it's wrong to want to see a chiropractor for this and see if that can provide any more solution potentially. I mean, a lot of times practitioners are threatened when you say you want to see another practitioner for multiple reasons. Some because of just simply, their own mind, sometimes because it might affect them financially if you're going to see somebody else as well. So there's a lot of things behind that, but my opinion on that is I'm always happy when patients of mine have ever gotten a second opinion because they wanted one if they felt they needed one.
Well, pardon me. I as per WSIB request, I am seeing an orthopedic surgeon and a clinician on this coming Friday, and for an assessment, which worries me because in the letter for this clinic, they said possible surgery, and I don't like surgery. I don't like invasive surgery. Yeah. So. Do you know if it's forced?
No. You can never be forced to do something. Again, their job will be to make a recommendation that they think is most ideal. You will never be forced to do an intervention. So, but it is always important. You have to understand when nobody recommends surgery because they just want to recommend surgery. If they're recommending it, it's often because it's probably required. But that's a conversation that you have with the surgeon. Right, where could you delay it? Are there other options first? And I mean, most of the surgeons I work with will always try to do other things before they get to that.
Oh, thank goodness. Oh, thank you so much. Okay. That gives me relief. No problem. I thought we were living in a Stalinist
No. We're out of that era.
Thanks, Justine. 1-855-55 Dr. Lou, DRLOU, to follow up. Brad, got about a minute or two here. If you want to rip it off really quickly, we'll get you an answer. Go ahead.
Okay, hello, Dr. Lou. How are you today?
Good, you?
Good. I just had a quick question. About 3 weeks ago, I was getting up from my desk at work and real pain in my lower back. I went to a chiropractor.
Yep.
Diagnosed with inflammation of the SI joint.
How was that diagnosed?
He was basically putting his hands around my body, a little bit of stretching.
Okay, so the only way to truly know if there's inflammation is either an MRI or a bone scan. So that's an assumption thus far.
Okay, so that's what has been done. He said, 2 or 3, week to 10 days should be
yeah, that he might very well be right that it might be like irritation of the SI joint. But when I hear inflammation of the SI joint, I start to think of systemic problems that can cause that. I would continue the treatment because it seems like it's very benign, like this just happened. Get the treatment as you've been suggested. If after that you're not feeling any better, give me a call.
Okay, well, it's been about 3 weeks, and I saw a massage therapist who said the SI joint is definitely not moving; it's still locked. So
okay, well, give me a call and let's take a look at it.
Brad, appreciate the call. The last moment of the show here, 1-855-55 Dr. Lou, DRLOU. Please reach out and go to info@paincarecanada.com. That's for you as well. If you didn't get a chance to call it today, we'll pick it up next weekend. Dr. Pain Show, Global News Radio 640 Toronto.